Good evening, friends. I'm back after a long gap. Thursday was Karnataka College of Obstetrics and Gynecology program. Friday was Manipal OBG Society program. Saturday, Sunday, I was having a weekend at Pelling. So I was traveling. So I'm sorry I could not take classes on those 4 days. I'm back with the abnormal uterine bleeding management part. There's lots to cover, so I don't want to waste time in recapitulating the classification, etc., which I already did in part 1. So today, let us straight away go into the management of AUB. I was talking about the different characteristics of palm coin. Let us restart from there so that we can quickly recapitulate the palm coin. Symptom-wise, if it is polyp, intermenstrual bleeding, and there will be infertility, obviously, because that will come in the way of ascent of the sperms. Intermenstrual bleeding because the polyps can get infected and that will start bleeding in between. That is a surface bleeding, and there would be normal menstrual cycle as well. Adenomyosis, it will cause congestion. There will be heavy menstrual bleeding, and there will be congestive dysmenorrhea as well. Leiomyoma, almost the same thing, heavy menstrual bleeding and congestive or spasmodic dysmenorrhea if it is submucous fibroid. So it is always the confusion between adenomyosis and leiomyoma. I will tell you how to clarify that confusion in the next slide. As far as malignancy is concerned, the typical post-coital bleeding in carcinoma cervix or post-menopausal bleeding in case of endometrial carcinoma and other carcinomas. Unscheduled bleeding, that is the cause because of surface bleeding. Signs. Uterus is normal, obviously, in polyp because polyp is outside the uterus. Os is spatulous because it is coming through the os. And always you can see a polyp extruding through the os. Adenomyosis is regularly enlarged uterus. There are 3 uteri that are regularly enlarged. Number 1 is adenomyosis. Number 2 is endometrial carcinoma. Number 3 is pregnancy. How do you differentiate between them? Pregnancy is soft, adenomyosis is firm, and malignancy is hard. In all the 3, regularly enlarged uterus. Of course, in pregnancy, you additionally have amenorrhea and other symptoms. Whereas myoma is typically described as irregularly enlarged firm uterus. One odd case can be a regularly enlarged uterus. Suppose there is only one fibroid that is in the center of the uterus. Usually not. Fibroids are multi-centric in origin. And as I said just now, it is an enlarged uterus, maybe regular also, but it is hard uterus if it is malignancy. Ultrasound-wise, of course, you can see thick endometrium because there is hyperestogenic state giving rise to polyp. And if you do SIS, echogenic mass sometimes can be seen inside the cavity. Adenomyosis, I have already described 8 different types of ultrasound picture and the MRI picture as well. There will be obscuring of endometrium myometrium junction. That is very important. Multiple hypoechoic halo zones or lakes in the myometrium. Whereas leiomyoma is unmistakable. They are well defined, spherical because of a pseudocapsule, hypoechoic areas with sometimes the shadowing behind that. Thickened endometrium, obviously in malignancy, irregular endometrial lining in case of endometrial carcinoma. Of course, carcinoma cervix, there can be sometimes in a collection inside the uterus called pyometra. Otherwise, it may be just a thick endometrium. You can see the thick cervix or a hard cervix or a cervical lesion through the ultrasound. Coming to the coin part of it, coagulopathy, ovarian dysfunction, and endometrial dysfunction and iatrogenic. Symptom-wise, there will always be family history of coagulopathy or history of bleeding, easy bruisability and things like that, and puberty menorrhagia typically. Ovarian dysfunction, there will be amenorrhea interspersed with irregular cycles and things like that, unpredictable and extreme heavy menstrual bleeding. In fact, when we used to talk about DUB, anything and everything can be there in a DUB. There can be polymenorrhea, oligomenorrhea, there can be menorrhagia, things like that. Similarly, here it is unpredictable, extreme heavy bleeding in the new terminologies. Endometrial type of problem, there will be predictable. That is the difference between ovulatory dysfunction. All of us know that the cycle length is determined by the ovary, whereas uterus does not have that capacity. The uterus will only behave as per the orders of the ovary. But that's why it will be predictable, but cyclical menstrual bleeding, which may be heavy or light or things like that. As far as iatrogenic is concerned, unscheduled varying amount of bleeding depend upon how the patient is been irregularly taking hormones, or if there is, let's say, copper T, which is again can cause inflammation, aseptic inflammation. Signs: uterus is normal, obviously, in coagulopathy, easy bruisability. You can also have telltale evidence of petechiae in the patient. In ovarian dysfunction, obviously, you will see the signs of PCOS, polycystic ovary, and oligomenorrhea type of picture. Endometrial, uterus is normal, maybe slightly thickened endometrium. Iatrogenic, uterus is usually normal in size. Ultrasound-wise, coagulopathy, normal uterus, maybe sometimes you can see cysts in the ovary, whereas in ovarian dysfunction, definitely you will see thick endometrium and polycystic ovarian picture. Endometrial type of DUB or AUB, normal uterus again. Iatrogenic, again, normal findings with a thick endometrium if there has been a copper T or a estrogenic intake. So how do you evaluate? History is very important. You should note the scheduling as well as pattern of bleeding. If it is heavy, it is suggestive of uterine in origin. If it is light, it could be either uterine or ovarian. Timing is important. If it is postmenopausal, for example, it could be carcinoma cervix straight away. Postmenopausal, it is endometrial carcinoma. Medical disorders, thyroid problems, and adult thrombocytopenia, you know the cause of the AUB. Medication, antipsychotics will give rise to long tenures of amenorrhea. Usually we need to counsel the patient properly because antipsychotic drugs are more important than having regular cycles. They should not give up antipsychotic drugs. You should not stop them unless you have consulted the psychiatrist. Similarly, anticoagulations, you know, that is the reason why they are having bleeding. Contraception and the type of contraception that they are using, COC or copper T, should be asked. Family history of bleeding disorders, it will talk about the coagulation disorders, and easy bruisability is also pointing towards that. Examination wise, it is very, very mathematical and typical examination that follows. The protocol should be speculum examination first is something like inspection. In medicine, they are very clear: inspection, palpation, percussion, and auscultation. So here percussion may not have much of role, but inspection definitely. Speculum examination is the minimum so that you can make out what is the source of bleeding and if there are any local causes, including vaginal causes, cervical causes, mainly cervical causes. Pap smear should be taken before you do anything else, before you use the even the lubricants to do a vaginal examination. So as soon as you do the finish with the speculum examination, a pap smear has to be taken, if not taken in the last 3 years. Bimanual examination follows. Uterine and adnexal pathology can be made out very easily. I remember we had a faculty who had a teacher in Manipal whom we used to call having ultrasonic fingers. She would just do PV and say, there is a small 3 millimeter cyst I can make out and things like that. Even MRI cannot make out such small things. But jokes apart, bimanual examination is very, very important, though we have lost the art of doing that. For everything, we now go for a transvaginal sonography. Pregnancy test is important because you have to rule out pregnancy always. The dictum in OBG is that unless proved otherwise in the reproductive age group, every person should be considered as pregnant. married and unmarried, sterilized or unsterilized, whatever it is. A minimum thing could be a beta HCG, if you don't want to call it a pregnancy test, because some women may get offended if you say, I want to do a pregnancy test. Just a beta HCG is important. Lab tests obviously include CBC, coagulation profile, and hormones. Imaging, ultrasound, without which we cannot practice OBG anymore. You can make out the lesions, you can note the endometrial thickness, etc. And if in doubt, you can go for MRI. Colposcopy, if the pap smear shows positivity. Cervical biopsy, if the colposcopy shows any particular lesion. Endometrial sampling, again, is a must in a case of AUB, especially in the second half of the reproductive age group, that is after the age of, let's say, 30, 35. Pipelle sampling is good enough, but hysteroscopy is the gold standard, especially in very thin endometrium. Sometimes you may not get much, so you may have to do a hysteroscopy and guided biopsy. So that's the endometrial picture for you in ultrasound. You can see here the thick endometrium, and here is the sonohysterography with the contrast of saline. You can nicely make out the endometrial cavity and things like that, if there's anything inside. Now I come to the most important thing, management. I want to go slowly. In fact, Dr. Savitri, Madam, Ramesh, Madam from Madurai told me that usually we hurry up talking more about the differential diagnosis classification, and when it comes to management, we just run through. So today I want to dedicate a lot of time, at least about another half an hour to talk about management. It is very important, especially in the adult life. The management of AUB is very important. Even in the adolescent life, it is an important issue. So I'll first talk about management algorithm. If it is a chronic AUB, other day I was talking about chronic AUB, chronic on acute on chronic and things like that. 3 months of excessive duration, volume or frequency or unpredictability, that is called chronic AUB. Just one episode of heavy bleeding is not good enough to call it chronic AUB. So there should be also a variation in the frequency, and if it is unpredictable for last 3 months, that's called chronic AUB. If it is not, then it is not chronic AUB. So you don't have to bother much. Manage it as an acute AUB, wherein if the bleeding is heavy, your concentration is towards stopping that particular bleeding. You don't worry much about the maintenance type of therapy. That is the meaning of this. But if it is a chronic AUB, then you need to evaluate the reason behind it, palm coin mainly. And not only you have to control the current episode, you will have to think of the subsequent episodes of AUB. Initial evaluation would include a structured history, what I already explained, and ovulatory function and future fertility should be asked about. The patient, if she wants fertility, then the management is different, obviously. If she is only worried about the AUB, then the management is different. For example, if she has got a fibroid uterus, and or if she has got adenomyosis, and if she has completed family, the management is going to be totally different from a very young girl or lady having this kind of problem. Medical disorders, medications, lifestyle, I have already explained to you, this history has to be taken in detail. Physical examination, basically uterine evaluation, and of course, the adnexal evaluation. Ancillary investigations include the usual ones, CBC, coagulation factors, and you can also test for endocrinopathy, inherited coagulopathy, for example, hypothyroidism and prolactinemia, hyperprolactinemia, and inherited coagulopathy, von Willebrand syndrome, and things like that. So that is to be done very, very elaborately. Uterine evaluation, of course, includes enhanced risk for hyperplasia and or neoplasia. If you suspect because of the patient profile, obese patient, hypertensive, diabetic, and family history of endometrial cancer, then endometrial biopsy is a must and minimum. If you get adequate specimen, then it's one thing. If you don't get, then you go back to endometrial biopsy. Simple. If you get adequate specimen, whether it is atypical hyperplasia or cancer, if the answer is yes, manage as AUB-M malignancy. I'm going to talk in detail. Suppose the patient is not having enhanced risk for hyperplasia or neoplasia, you can straight away manage it as a case of AUB-E, that is endometrium, or AUB-O, that is ovulatory type of endometrium. AUB rather. Suppose it is not atypical hyperplasia or cancer, that case also is managed like a case of AUB-E and AUB-O. Next thing is, there is enhanced risk for structural abnormality. Then you do an ultrasound, transvaginal sonography. If the cavity is normal, then of course you can manage it like a case of AUB-E or O. That means AUB-E and O are very important and commonly thought of, which was formerly called DUB. If the cavity is not normal, then you do a hysteroscopy guided biopsy. There also, if the specimen is inadequate, you have an option of either doing an endometrial biopsy, or you can straight away go for hysteroscopy guided biopsy. This I'm showing it to you now because I was waiting for this box to come up. Suppose the cavity is not normal, you can also go for, if you don't have hysteroscopy in your office, or if you find that it is expensive, invasive, you can go for a contrast sonohistography as well. Now, either hysteroscopy or contrast sonohistography, they show a target lesion or they don't show a target lesion. Manage it as again case of AUB-E or O. So AUB-E or O is very important. Endometrial AUB or ovulatory AUB. So if again here you have come from the previous slide, I have already shown you that atypical hyperplasia is not there. Again, it is managed as AUB-E or O. Suppose the target lesion you could not assess properly. Here it is clearly no, but here you could not assess properly. That's the time you go for an MRI. Straight away, don't go for MRI. Who goes straight away for MRI? UG students. In the examination, they know X-ray, MRI, CT scan are available on earth. They will write all the three and leave it to the examiner to choose. But we don't choose like that. We go stepwise and then only we come for that. Suppose the hysteroscopy or contrast sonography reveals the target lesion, then you must manage accordingly, either as, let's say, leiomyoma or a polyp or adenomyosis, as the case may be. So now I go one by one, palm coin. First of all, AUB-P, polyp. Simple or hysteroscopy guided polypectomy. Again, in polyps, there are many types of polyp: a fibroid polyp, an adenomatous polyp, or adenoid polyp, or sometimes mucoid polyp. A small polyp, mucoid polyp, or even adenomatous polyp, sometimes in the OPD itself, you can just twist it off and remove it. There'll be some bleeding which will stop on its own. But sometimes it may have a thick fibroid stalk or a fibrotic stalk. Then probably you will not be able to do it in an OPD basis. You may have to take her under maybe monitored anesthesia care, clamp it, cut it, sometimes even ligation is required. If the polyp is a little bit sessile inside, somewhat like a, let's say, leiomyoma type 1, which is mostly into the cavity, but there is a small or there's a sessile stalk, then you may require a hysteroscopy. Whatever it is, if there is a polyp, there is no conservative line of management at all. And these things are not amenable for hormonal treatment. Like, fibroids, you may sometimes try GnRH analogs or mifepristone or even ulipristal. These polyps are better removed. They should be removed. It should be sent for histopathology. Nothing that you remove should be thrown into the dustbin. It should be sent for histopathology because anything can be having a problem, especially sometimes on the polyp, you may realize there is an endometrial carcinoma. So you cannot throw this out. Sometimes there can be polypoidal endometrium along with the polyp. So after polypectomy, routinely, some gynecologists do a D&C. I leave it to your experience or your practice. You can do that if you want. But whatever it is, send both polyp as well as endometrium for histopathologic examination to rule out endometrial cancer. Depending upon HPE, suppose the HPE says there is simple hyperplasia without atypia, or sometimes complex hyperplasia but without atypia. Both of them you can manage further by giving medroxyprogesterone acetate 10 milligrams day 5 to day 25. It is better to give throughout the cycle to almost like simulate or suppress the endometrial hyperplasia 3 to 6 months. So now why 3 months? Why 6 months? If it is simple hyperplasia, 3 months are enough. If it is complex hyperplasia, 6 months you have to give. The latest classification is so simple and easy. There are only two: simple hyperplasia, complex hyperplasia. Both of them can be with or without atypia. Whereas when I was a PG, we used to have 5 things. First one is hyperplasia, simple hyperplasia. Then we used to have what we call cystoglandular hyperplasia, adenomatous hyperplasia, atypical hyperplasia, then malignancy. We used to say first 2 only medical line of management, last 2 surgery, and the middle one, that is adenomatous hyperplasia, depending upon the age of the patient, depending upon family history of malignancy, duration of treatment, and the response to the previous treatment, we would decide whether to go ahead with again some sort of progesterone treatment or not. Now things are very clear. There is no confusion at all. Simple hyperplasia, 3 months, complex hyperplasia, 6 months. Suppose the patient has got high risk for malignancy, then you may consider, again doing a histopathological examination. And if you see any atypical hyperplasia, go for simple hysterectomy, provided she has completed the family. Now, there is a lot of confusion among many gynecologists whether to give norethistyrone or whether to give medroxyprogesterone acetate whenever there is hyperplasia. I want to clarify it right now. Norethistyrone is a very potent progesterone, and it is like a testosterone derivative. You would use that in the first episode or a heavy bleeding situation. That preferably should not be used for maintenance therapy. I hope I'm clear. So in an acute episode or a first episode of heavy menstrual bleeding, you may start with a very high dose of Primalute N or anyway norethistyrone acetate 5 milligrams 3 times a day. Then after 1 week of that, you may taper it down to 2 times a day for 1 more week and 1 time a day for last week. Many patients do not understand this. So what I and even Dr. Pratap, all of us do there is that first week we give 3 times a day. The next 2 weeks we give 2 times a day. So total 21 days. After that, it is almost like a medical curettage. But subsequent cycles, we do not give Primalute or the norethistyrone acetate. We only manage with medroxyprogesterone acetate, 10 milligrams day 5 to day 25, 3 to 6 months. I hope I'm very clear in this. This has really revolutionized the treatment of AUB, LNG-IUS, though it came as a long-term contraceptive device, but it is very, very good because it is locally acting. It will double up as contraceptive as well as agent against the heavy menstrual bleeding, basically tackling the hyperestrogenic state. If there is no atypia, you can go ahead and insert LNG-IUS. The only thing is you have to explain to the patient properly that it may take its time to start acting because it is supposed to act for 5 years. So it will give only that much, less than 20 or 50 micrograms per day locally. So to build up the hormonal level, first couple of months, usually I at least give medroxyprogesterone acetate 10 milligrams continuously for 2 months. And by that time, LHG-IUS starts working, and thereafter, even if you withdraw MPA, nothing will happen. She will slowly go into permanent amenorrhea. That's the aim actually. And the follow-up required only is after insertion, after 1 month, you call her to see whether the system is in place, and then once in a year only she has to come. After 5 years, probably you can remove it and reinsert if she's still young, and still, if you think that she still has got some more time before she attains menopause. Adenomyosis is a big challenge. The next one in the palm coin after P is A. Adenomyosis is a very, very big challenge. And we earlier thought, when I was a PG, we used to think that adenomyosis is possible only in the, after the many multiparous ladies. After many deliveries to the crevices, the endometrium goes into the myometrium, and that's where it happens. But now we know that very young patients also can have adenomyosis, and this can give rise to even infertility. So with the infertility, the treatment becomes a little more complicated because you cannot go for a definitive treatment, which is hysterectomy, of course. Young infertile patient, there is a surgery called adenomyomectomy, xenomectomy. My good friend Zainul from Professor Zainul from Malaysia, he calls it as xenomectomy, xenomectomy, and adenomyomectomy by methods suggested by Japanese gynecologists. Also, you can do that. And best treatment for adenomyosis is IVF. Even for endometriosis, best treatment is IVF. LNG-IUS, you can insert. It may not actually decrease adenomyosis, but it will definitely decrease the bleeding because of adenomyosis. Because again, it is acting locally and it is suppressing the endometrial growth. So LNG-IUS is a good option. On a long-term basis, it may slightly shrink the adenomyotic areas, but definitely it will improve the symptoms. Question mark GnRH-A, because these hormones do not reach the adenomyosis. That is the problem. GnRH analog is fantastic for endometriosis, but not for adenomyosis. Maybe because the type of endometrium that you see in adenomyosis is different from the type of endometrium that you see in case of endometriosis. Maybe these are like basal type of endometrium, which is getting into the myometrium. So GnRH analogs are not very effective. However, one can try that. HIFU has again been tried like in fibroid uterus, that is high frequency ultrasound with the magnetic resonance guidance. But again, the reports are not very encouraging. What about uterine artery embolization? Again, I put a question mark. The results are not very, very good. Elderly and completed family, hysterectomy is the best treatment for adenomyosis. Leiomyoma, I'm not going to explain in detail because I took a full 40 minutes class on that. Suffice to say, the first line is tranexamic acid or progesterone to control the symptoms. Myomectomy in younger infertile patients, GnRH analog, LNG-IUS, UAE are conservative management. HIFU also is in the list, whereas mifepristone, ulipristal, I have put question mark. I have explained that in the last class. Hysterectomy is only for elderly, those who have completed the family. For AUB-M, that is malignancy, each one is a chapter by itself. Carcinoma cervix I have taken in length. Today I'm not going to go into details of that. Endometrial carcinoma, I will take another day class, and ovarian malignancy giving rise to AUB, I will tell in one slide. As per the histopathological type and grade is the management. Of course, stage is also important and age is also important. Let's see how it is important. In carcinoma cervix, cone biopsy is both diagnostic and therapeutic. Removal of cone of cervix is very important, nicely including the involving the entire SC junction, stroma and glands, and endocervical mucous membrane as well. What are the indications? Unsatisfactory colposcopy. Microinvasive carcinoma on biopsy, you want to reconfirm that it is definitely not invasive. Discrepancy between cytology and colposcopy, reconfirmation is by cone biopsy. And finally, adenocarcinoma in situ, this could be sometimes therapeutic as well. Positive endocervical curettage for CIN2 and 3, the final confirmation is by cone biopsy. The management of precancerous and cancerous lesions. Precancerous lesion like CIN1, just observe with strict follow-up. CIN2 and 3, because that can go back. Whereas CIN2 and 3, cone biopsy is always better. You can also use LEAP or laser. CIN3, confirmed by cone biopsy. Simple hysterectomy is good enough if patient is not reliable for follow-up. Otherwise, cone biopsy is enough for those patients. For invasive cancer, stage 1A1, which is microinvasive cancer, simple hysterectomy is good enough, provided it is not associated with lymphovascular invasion after histopathological examination, and she has completed the family as well. Conization with negative margin also can be considered for stage 1A1. Not completed family. For those who have not completed family, they want to retain the uterus, conization is good enough for them. Whereas stage 1A2, A2 is, again, macroinvasive, B1 and B2. Now there is new entrant called B3. B3 means more than 4 centimeters. So I have not put B3 here, though it is stage 1. And in stage 2, again, it is divided into A1 and A2. A2 is more than 4 centimeters. Anything more than 4 centimeters, you don't do surgery. So only A2, B1, B2, and 2A1, both surgery and radiotherapy are equally effective. You would go for radical hysterectomy if a patient is young who wants to preserve sexual as well as ovarian function, because if you give chemoradiation, ovaries are knocked down. Radical hysterectomy includes uterine removal, plus or minus tubes and ovaries, upper third of vagina, parametrium, medial to the uterus, primary draining lymph nodes, that is parametrial, obturator, internal and internal iliac nodes. So that is what is removed in Wadham's hysterectomy, which is the commonest radical surgery done for carcinoma cervix. Management of stage 1B3. B3 means more than 4 centimeters, and stage 2A2, also more than 4 centimeters. And of course, 2B onwards. See, the old teaching was anything more than 2B is for radiotherapy, anything less than 2A is for either radiotherapy or hysterectomy, depending upon the age of the patient. But now in 2A and less, there are two things, that is B3, 1B3 and 2A2. These are more than 4 centimeters. And even though they belong to stage 1 and stage 2A, hysterectomy is not a choice at all. Chemo radiation is the only treatment for these patients. 2B onwards, 3 and 4, A, B, C, or whatever. Whereas stage 1B3 and stage 2A2, these are for chemo radiation only. Endometrial carcinoma stage 1A, which is less than 50% of the myometrium, TH-BSO, LNG-IUS also can be given. LNG-IUS is only for those infertile patients who are waiting for IVF. And for them, in fact, high-dose progesterone is also considered. 6 months of high-dose progesterone, something like 30 milligrams. I have heard people give 3 times a day or even 30 milligrams twice a day. It is very high dose of progesterone. After 6 months, they repeat the endometrial sampling. And if it is normal, they do IVF. And after the delivery of the baby, they go for TH-BSO. Stage 1B onwards, no choice at all, because lymphovascular invasion is guaranteed, which is more than 50% of the myometrium. You have to go for TH-BSO with post-operative radiotherapy is a must. Ovarian cancer, especially the hormone secreting type, which will give rise to AUB. If it is juvenile type, pre-pubertal, or in younger women, endometrial hyperplasia or adenocarcinoma, staging laparotomy has to be done. TH-BSO is the answer, and follow up it with post-operative chemotherapy. In younger patients, usually BEP regime, bleomycin, etoposide, and platinum. Whereas adult type, which is 10% of the cases, the treatment is almost the same. So in fact, there is no need to really differentiate between juvenile type and adult type, because ultimately they will undergo THBSO, post-operative chemotherapy. It is BEP regime again here. I think I should stop here because AUB coagulopathy is a slightly bigger one. I am seeing that 5 minutes are left. Let me see if I can finish. Let me finish. This history is common for all AUBs, but for coagulation problems, you have to take family history of bleeding disorders, easy bruisability, heavy bleeding during dental extraction or any trauma, contraception methods used, and medication used, anticoagulants and antipsychotics. Finally, medical disorders can give rise to coagulation problem. Special medical disorders like ITP, ATP, CTP should be asked for. Liver disease, rule out that. Especially hemostatic abnormalities are common in that. Kidney disease, platelet dysfunction is seen in uremia. Connective tissue disorders, again, SLE. Hypothyroidism, because there can be acquired von Willebrand syndrome in such people. Cancer, because anti-neoplastic therapy or progressive disease both can give rise to thrombocytopenia. Excess of alcohol, because hematologic complications are seen in those who take alcohol. What are the drugs, medications? Anticoagulants, because they interfere with clot formation secondary to hemostasis. Antiplatelet NSAIDs interfere with platelet function. Primary hemostasis, all of us know that. Primary hemostasis is by platelet function, secondary hemostasis by clot formation. Accordingly, you have to use. Glucocorticoids will interfere with vascular integrity. Antibiotics, they cause vitamin K deficiency, especially with longer use, some interference with platelet function. And SSRIs interfere with platelet function, which is involved in the primary hemostasis. So if the patient is taking any of these drugs, you should be aware of that. Otherwise, you don't know how to treat them. If the patient is taking anticoagulants, you should realize that the AUB is because of that. But before stopping that, you should consult the physician who started it. Suppose the patient is taking antiplatelets, NSAIDs, then just stopping that would improve the AUB. Glucocorticoids and antibiotics, of course, antibiotics are temporary ones, whereas glucocorticoids, again, ask the physician before you stop them. Alcohol, complications of liver disease may affect clot formation and may cause thrombocytopenia due to direct marrow toxicity as well. Finally, vitamin E interferes with vitamin K metabolism in some individuals. So we think that vitamins are always good, but